So hi guys. Uh, okay. So hi guys, can you see me? Yes. Shall we start? Let me see. Okay. Right. Okay. So that's everybody. Yes. So welcome to the midnight session, guys. So let's have a quick rapid fire of hemat instruments. Take it as a quiz and just see how many questions you can answer. Okay. So on your screen, question number one. Okay. So here is the image shown. Okay. So you have to identify what is the technique shown here. So what is this technique that has been shown here? So guys, anybody who can tell me what is the technique? Yes, what is it? What is it? Come on, come on, come on, guys. What is the technique? Answer, 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 answer. It's rapid fire quickly. Good evening, Ankita. Good evening, Chandni. Good, good, good. What is the technique? Okay. So what do you see here? This is a brush, okay, and they are putting something in a this brush. They are putting in a vial, okay, and then they are processing it in the machine. So this is a very typical, very good Padmavati. This is a liquid-based cytology, okay. So this is a liquid-based cytology, and how is it different from the classical Pap smear preparation? Is that in this brush that has you have, so this brush is something like this, which they can give you as an image-based question also. So this is a broom, okay? This is called a cyto broom, and its head can be broken, and it can be put in this vial itself, so that all the material that you've taken, all the sample that you've taken, will stay inside the vial, and there's no wastage, okay? So when you break the head and put it inside the vial, this is what is called as sure path, okay? So liquid based cytology is of two types. Remember, guys, we have sure path and we have thin prep. Okay, so we have two types of liquid based cytology, right? Sure path and thin prep. Okay, so remember what is the difference between both of them? Okay, you have to remember this. So sure path is very commonly used in India, and it is an ethanol based fixator, just like your conventional pap smear, which is also ethanol based. Whereas thin prep, okay, which is very commonly used in abroad, okay, in some places in India also, is methanol based. Okay, so that's a methanol based preservative. That is what you have to remember. And once you've done it, what you do is, in sure path, you break the head. Okay, of you take the broom, you break the head and put it inside the vial only. Okay, so no material is wasted. And when it spins, the circle that comes is usually 13 millimeter of size. Okay, so circle, that means circle means, look at the circle here. That's the smear. That's a smaller area to screen. It is approximately 13 millimeter. Whereas what happens in thin prep is that you have to rinse the brush inside the vial, okay, and you get a bigger circle. So look at this circle here, you get a bigger circle here. This is approximately 20 millimeter in size, okay. So if you look at this smear, this is the conventional, okay. So this is how a conventional pap smear looks like. This is how a sure pap look like, okay. This is sure and this is thin. Okay, so remember how to remember it. Sure means sure. You're sure nothing is getting wasted. So surely you're breaking the head and put it inside the vial itself. So this is sure. Okay, break the head, put it inside, it's sure path. Okay, thin prep is you just rinse it. Okay, and conventional, you already know that you just take it, you take the sample and just smear it over the slide. Okay, so the beauty of the smear is the sure path and thin prep is they're cleaner and they don't have debris, they don't have mucus, and the preparation is very beautiful. So there are some image spotters that can come for you in exam, and you should be very clear. Okay, so we'll be I'm just telling you this. Okay, so starting first with this slide here. Okay, so look at this. Always when you look at this smear, these large polygonal cells, okay, whenever you see, these are your squamous cells. So with pycnotic nucleus and a pink color cytoplasm, these are superficial squamous cells. Okay, superficial squamous cells directly mean estrogen rich condition. So whenever there is an estrogen rich condition, we have superficial squamous cell, whereas the blue ones are your intermediate squamous cells and usually indicate progesterone, okay, status of your body. So whenever a female is pregnant, you will see navicular cells or progesterone rich cells. Okay, whereas if you look at these cells here, these cells here are parabasal cells, which are rounded. They are little dark bluish to greenish in color, and they have a little larger nucleus. So parabasal cells means no hormone status, usually in postmenopausal. So P for P. So parabasal, basal means postmenopausal female. So here is the question that they can give you, and it was also a repeat question which came in the exam. So 65-year-old female presents with presents to you with pap smear examination, and on examination of the 65-year-old female, you are seeing these cells on pap smear. What can be the diagnosis? So 65-year-old female, when you see superficial squamous cells only, that means estrogen rich condition, you should always think of estrogen secreting tumor. Most probably at that age is granulosa cell tumors, and all of you know that what are the bodies which you see in this. So they are, if you do the biopsy, you'll be seeing connexional bodies in the ovary, but in pap smear, so this is one tumor. Which ovarian tumor can be picked up on pap smear? It is granulosa cell tumor. You will see a lot of superficial squamous cells. Everybody clear with that? That's one question that can be asked to you in your exams. Now there's some spotters that they give you in pap smear, okay, directly. So first spotter on the screen here, what are these cells? So these cells are coilocytes. Can you see? You can see resinoid nucleus with the perinuclear halo. These are coilocytes indicating HPV infection. And whenever we are looking with viruses, two viruses you should be knowing in pap smear, HPV and HSV. So this is HPV where you see coilocytes, and look at this. Never forget, this was also a repeat question which came in the exam. Multinucleate giant cells, 3 M's you have to remember. What are the 3 M's you should remember? Margination, molding, multinuclearity. So you see multinuclearity, you see margination, that is the chromatin is at the periphery, and of course you also will be seeing multinucleation, margination, and molding, because the nucleus is uh, bending against each other. So that is what is called as molding. Okay, so that is your HSV, which you all have to remember. Next image that is given to you here is this. So look at this image. What is this? Remember, whenever we have a liquid-based cytology, it is clear. And on liquid-based cytology, if you see candida, you see them spearing the squamous cells. Remember, what is this called? Shish kebab effect, which is seen in candida, which you should always remember. Seen in candida, this is called shish kebab effect. Okay. Once you are clear with this, look at Mona Darling of the pap smear. Who is the Mona Darling of the pap smear? You already know this. Okay. So quickly remember, whenever I'm talking about this, so this is my dear Mona Lisa with one winking eye and an undulating hair. Who is this? Come on guys, you have to identify this. Who is this with my dear undulating hair? Who is this? Come on, what is this? Come on girls. Mona darling versus a two-eye sparing boy with mustaches coming here. Yes. So this is my Mona darling, which is tricky Mona. Okay. So trichomonas. Yes. So this is tricky Mona with one winking eye and an undulating hair. And this is your Giardia, which you see in your intestinal biopsies. Okay, so Giardia has two staring eyes, and if you have one eye with an undulating hair, this is your Giardia. And you know, this undulating hair usually goes in the background. So whenever you have Giardia, there is a background uh, organism which is seen in this case, which is called as leptothrix. Remember, leptothrix is the organism which is seen in the background of trichomonas, which always you should remember. If you've seen if you've seen leptothrix, you will never forget it. Let's quickly see leptothrix. Okay, so remember guys, this is a normal lactobacilli which is seen normally in a normal female of in the pap smear, and this is very important for maintaining the pH. But instead, if it is usually whenever we have these long undulating organisms, what are they called as? Leptothrix, and they're usually associated with trichomonas infection. Okay, so remember that always guys. Okay, so once we are clear with this, there's another spotter that they can give you in pap smear that you have to remember is this. All of you know who is this? Actinomyces. This is, a cotton ball-like structure usually seen in IUCD users. These are actinomyces. Remember, actinomyces, they can give in tonsils also because it is a commensal of tonsils also. So, but in cases of IUCD users, you have to remember they can be seen in pap smear. Okay. And who is this? Who can identify this? Mr. Tadpole in the picture house. Who is this? Orange color cell with a big nucleus, okay, like a tadpole. This is a tadpole cell, and it always indicates, because it's orange, that means keratin, it is well differentiated squamous cell carcinoma. So whenever we have well differentiated squamous cell carcinoma, we have tadpole cells, that you should always remember, right? So these are the changes in pap smear that they give you. Remember the instrument that I told you, normally you use pap smear, but nowadays majority of the institutions have sure pap. And now next question is liquid based cytology used only for pap smear, or it can be used in other places also? So nowadays we are using it at other places also. Okay, so even for a fluid examination at other places like bronchoalveolar lavage or processing of fluids, we are using liquid based cytology. Okay, because the technique is so beautiful that the results are very good. Okay, so it's not unique to only pap smears. Okay, now let's come to the next technique, okay, which is another tricky question. Let's see. Okay, so this question is based upon hematology. So the question is, which test am I showing you? This patient, which test is this if the solution here contains phosphate buffer, sodium diothionate, and saponin? So what do you think is the test that is shown here? Obviously you can see here that in this tube you cannot see lines, okay, background lines, you can't see them, whereas you can see lines in this, you can't see lines in these cases. Okay, so all those marked with the yellow ones, you can't see lines in the background. So which test is this? So very good, guys. So whenever I say that I'm using sodium diethionate basically breaks the cell RBCs, breaks out the hemoglobin, breaks down the red cells, take out its hemoglobin, and in case the hemoglobin is sickle hemoglobin, it's not soluble. Okay, so what will happen is the solution will become turbid and you can't see the line. So this is not Nestrov. Okay, that is Santhan and Shushmita. Remember, this is not uh, Nestrov. Whenever I say a solution containing sodium diethionate, this is Sickle solubility test. Okay, so you have to remember the constitution of the solution. Okay, phosphate buffer, sodium diethionate, and saponin is basically used for Sickle solubility test. Okay, right? Okay, Kishore. So this is Sickle solubility test, not Nestrov. Okay, so remember that. In contrast, so this is Sickle solubility, which I showed you. In contrast, look at this, which everybody of you answered. If I change the question and I say that you are using 0.36% saline and now you are putting patient sample in it and you are seeing this, okay, then what is going to happen? So then this is Nestrov test. Why? Because at 0.36% in all you and me, all our red cells should lyse. So when the red cells lyse, they settle at the bottom and the solution becomes clear and you should be able to see red line. Okay, so whenever you're seeing the line at the background, that means the red cells have lysed. But even at 0.36%, if red cells are not breaking down, if they're not lysing, that means that these cells are usually either they are target cells which have excess. What is target cells? Target cell is nothing but a cell with more surface area to volume ratio. So surface area is so much. Imagine a snake, okay, big snake, and you're fitting that snake into that small box. Okay, so what happens in target cell? Surface area is excessive, so it fits into that excess volume of the epithelium has to fit. So it fits like a target cell. So there's an inside hemoglobin. It appears like hemoglobin, but actually it's an excess membrane. Okay. So either it is a target cell or it is a microcytic hypochromic cell whose volume is less, and that is why relatively surface area is more. So what happens is in patients of thalassemia trait, they thought that these cells should not lyse at 0.36%. So it was used as a screening test for thalassemia. Okay, basically thalassemia trait in pregnant females. So this is called naked eye single tube red cell osmotic fragility test. Okay, so naked eye, okay, single tube red cell osmotic fragility test. But problem was this test failed in our country because majority of the antenatal patients who presented in the OPD were having iron deficiency anemia. So they had microcytic hypochromic cells. So even with microcytic hypochromic cells, what will happen is it will keep on taking fluid, more and more fluid, and it will not lyse. Okay. So that is why this test was not very successful. It was used as a screening test of thalassemia trait. So remember the difference between both of them. Okay. So that upper one with diethionate was sickle solubility test, whereas with 0.36% saline, it is Nestroft. Don't get confused between both the tests. Okay. Now, if you look at this, once you're talking about osmotic fragility test, guys, you have to know this test. Okay, so what is this test? This is osmotic fragility test. So what do you do? Percentage of hemolysis on y-axis and percentage of saline on the x-axis. In UN, normally what will happen is the lysis usually start occurring at 0.5 and complete 100% lysis usually occurs at 0.3%. Okay, but in patients of hereditary spherocytosis or any spherocytosis due to any cause, there is excess. So what will happen in spherocytosis? So surface area to volume ratio is decreased now. So they don't have excess surface area to take more volume, and they will start lysing at 0.7 itself. And by 0.5, 100% of lysis will occur. So curve will shift to right. Okay. So that is what happens in hereditary spherocytosis or spherocytosis due to any cause. So first question on the for the day is osmotic fragility test. Nowadays we basically do incubated osmotic fragility test specific for hereditary spherocytosis. No, it just helps you in picking up. Yes, it just helps you in picking up that there is spherocytosis. It's not a confirmatory test. Yesterday we talked about all the mutations that cause spherocytosis, so we should know this. So what is the confirmatory test for picking up hereditary spherocytosis? It is a flow cytometry based test, guys. This test is called as EMA binding test. Okay, so it is a flow cytometry based test called as EMA binding test, which all of you should know. Okay, so that is EMA binding test, which is for hereditary spherocytosis. Okay, now let's come to this. If I say the curve is shifted to left more this side, that means either you have target cells or microcytic hypochromic cells, and that is thalassemia or severe iron deficiency anemia. Right, guys? Let's go to the two questions on the screen, guys, which are repeat questions, but there are some tricky points about it, so let's know about it. So first question: a child aged 2 years presents with non-specific symptoms of anemia, peripheral smear has target cells, also her microcytic hypochromic picture, the hemoglobin is very less, and there is a positive family history. What is the next investigation of choice? So guys, 2 years old child with microcytic hypochromic anemia with hemoglobin of 6, investigation choice. This probably could be a case of thalassemia trait. So the next investigation of choice will always be confirming the diagnosis either with hemoglobin HPLC or hemoglobin electrophoresis. That should be the diagnosis in this case. Okay, remember that. Okay. Now I change the question. This is the INICT November 2022 recall. The child comes to you with hemolytic phases, splenomegaly. Okay. Now this hemolytic phases, splenomegaly goes more towards thalassemia major. Okay, so what all investigations will you order? Now, which all investigations will you order in this case if they're asking? So when I'm saying that this is probably looking like thalassemia major, so the options were A, B, C, all 1, 2, 3, 1 or 2, 1 only, like that. So always you should do peripheral smear, and to confirm you should do hemoglobin HPLC. Okay, so these are the two investigations you should do in case of thalassemia major. Is bone marrow indicated from the first outset in thal major? No. Bone marrow is usually not indicated in patients of thalassemia major because you can make diagnosis on the peripheral smear and hemoglobin HPLC itself. PT and NIPT are coagulation tests, so no need not do them here. Okay, so the investigation is done as PS and hemoglobin HPLC, which you should be knowing, right? So once you know this, remember this graph here, guys. What is this graph? This is hemoglobin HPLC. So whenever you look at hemoglobin HPLC, you should always look at three hemoglobins at least, which you can see directly at an undergraduate level. Okay, so hemoglobin A should usually be more than 95%, hemoglobin AF nearly 1%, and hemoglobin A should be less than 4%. This is the normal arrangement that should be seen, and if there is any abnormal hemoglobin, that you should always look at. Okay, so in this case you can see that hemoglobin A2 is 4.9, that is, it is more than 4%. So you can see hemoglobin A2 is raised and it is actually more than 4%. So whenever the hemoglobin remember A2 is more than 4%, that takes you towards beta thalassemia trait or heterozygous beta thalassemia. Okay, so this is heterozygous beta thalassemia or beta thalassemia trait. But the catch point here is, what is the upper cutoff, okay, of this? It is usually 8%. So whenever hemoglobin A2 goes more than 8%, that means there's some other hemoglobinopathy which is coming in that window. Okay, and for an undergraduate, for your level, this is the question that they ask you. So let me ask you this question so that you can answer me. 26-year-old female from Assam presents for antenatal checkup. Her gynae advised HPLC. On examination, hemoglobin A2 is 25% and rest A is this much, AF is this much. What can be the diagnosis? So remember, guys, whenever hemoglobin A2 is more than 8%, always think of hemoglobin E. Okay, hemoglobin E. Now, because hemoglobin A is there, so there is A also and plus hemoglobin A plus A2 more than 8%. That means this is E. So A and E together, so two hemoglobins A and E. So this is heterozygous. Okay, so this is heterozygous HBE. Suppose if I say A is not there, only A2 is 90%. That will be homozygous HBE. So especially in the northeast part of our country, guys, hemoglobin E is very common. Okay, so hemoglobin E is very, very common in the northeast part of the country, and that is what you should always remember. Okay, so this is a trick question which they ask you, and students usually do it wrong. Remember, whenever A2 goes more than 8%, think of hemoglobin E, then look at hemoglobin A. If hemoglobin A is there, okay, if hemoglobin A is there at least more than 50%, it is heterozygous HBE. Whereas if A2 is more than 80%, then go for homozygous HBE, right? And these patients usually present like beta thalassemia trait only, and that is why it is important to differentiate them from beta thalassemia traits. Perfect, guys. Now look at this investigation. We had talked about this investigation yesterday also. What is this? What is this test which is shown here? Yes, so this is hemoglobin electrophoresis, okay, cellulose acetate electrophoresis, which you do on pH 8.5. And I have already shown you yesterday, okay, so that hemoglobin's movement we monitor. And of course, you have to know, we have already talked about it. So whenever it is a heterozygous state, you can see two bands like AS, this is heterozygous. Whereas if it is homozygous, you would be seeing only one band here, okay. So you have to differentiate heterozygous from homozygous. So this is hemoglobin electrophoresis technique. Okay, right? In contrast to that, what are the other electrophoresis that you should remember? What is this, guys? This is DNA electrophoresis. Okay, which you do in your apoptosis. So here you are not seeing any pattern here. So that means this is a live cell. This cell you are seeing step ladder pattern. Okay, step ladder pattern. This is because endonuclease breaks down, okay, at a fixed interval. So the size of these pieces are always 180 to 200 base pair size, okay. So fixed size is there, and that is why it gives you that step ladder pattern. Whereas look at this third one, this is a diffuse pattern, okay, which is also called a smear pattern, which you see in necrosis. Okay, so which you see in necrosis. So this is your DNA electrophoresis, which you can see, right? Perfect, guys. And the third type of electrophoresis is this. This is called as serum protein electrophoresis. This is called as serum protein electrophoresis. Remember, you have to use serum in it. Always use serum in it. You should never use plasma. So what is the difference between plasma and serum is? In serum, you just allow the blood to stand and clot by itself. So whatever is left on the top is serum. Okay, so what happens is the fibrinogen protein, the coagulation proteins are consumed in making the clot. So this serum is free from fibrinogen. So whenever you have to do any biochemistry tests or electrophoresis, you should take this. Okay, basically you have to do serum protein electrophoresis. Okay, what about plasma? Whenever you take blood in an anticoagulated vial, whenever you take blood in an anticoagulated vial and then you centrifuge it and then you see three layers, RBC, buffy coat, and plasma. That is plasma. This plasma is basically this plasma has all the coagulation factors, and these plasma basically used for coagulation test. So suppose I have to find out coagulation test whether a person has hemophilia or not, then I'll use plasma. And this plasma, if you use for platelet, if you use for coagulation studies, it has to be platelet poor plasma. So if I have to use for coagulation studies, I will use platelet poor plasma whose platelet count should be less than 10,000. Okay, whereas if I'm doing a platelet function test, then I will take platelet rich plasma. Okay, so two plasmas we can make: platelet poor plasma and platelet rich plasmas. Platelet poor plasmas are used for coagulation testing and platelet rich plasmas are used for platelet function testing. Okay, so remember, for this test which I am showing here, this is serum protein electrophoresis. You should always use only serum. Otherwise, fibrinogen will interfere in your reaction and your results will not be correct. And here you are seeing a broad, normally you should see a broad M peak like this. This is a polyclonal peak, whereas in this case you're seeing a sharp peak coming like this. So this is what is a spike. So that is why it is called as M spike. Remember, this is what is called as M spike, which is seen in multiple myeloma. And of course, you have to quantitate it to say it a multiple myeloma. You should have a criteria which should be fulfilled. That is plasma cells more than 10%, your M protein, okay, more than the given cutoffs, plus crab features. Okay, right. And if your crab features are not there, you should remember this slim criteria also, that is more than 60% plasma cells, okay, involved to uninvolved light chain ratio more than 100 and more than 5 millimeter lesion on MRI. That's a very, very important criteria you should remember in this case. Okay, right. Once we're clear with this, now let's come to some instruments that they ask you in HEMAT. Okay, so which is this instrument, guys? What do you think is this instrument? So all of you know this. This is a bone marrow aspiration needle. This is having a screw for adjusting the size. This is Sala's needle. Okay. And this can be done for bone marrow aspiration. Okay. Whereas nowadays we use Jamshidi's needle, which can be done used for bone marrow biopsy itself also. Also remember that whenever you are seeing a bone marrow, you have to see the cellularity of the bone marrow, which is calculated as 100 minus the age. If it's a 20-year-old patient, so the cellularity should be 80%. Okay, and the cellularity means cells and fat, and the ratio of cells to fat is 1:1. And when I'm talking about what are cells here, this is myeloid and erythroid, and the ratio of them is usually 3:1. Okay, so that is what you have to remember. Okay, so that's the needles that you should know. Another instrument that they give you in hematology is these vacuotenors, and you should know order of draw, guys. Okay, so first sample that you always should take is culture. Okay, that should be the most sterile one. Take culture first, and after that, after culture, you should always take citrate vial. Okay, so this is a blue color vial like this. This is citrate vial, which is for this is trisodium citrate vial for coagulation studies. So you have to take this first. Okay, now why do you follow this order of draw? So that cross contamination doesn't occur. So citrate coagulation is the first to take, so because if it gets contaminated with EDTA, then it will not clot at all. So you don't want to risk that. First is always you have to take with the citrate vial. Okay, after citrate, then you take for serum. Okay, so remember the code here is SHE, she. Okay, so she is teaching you. So she is serum vial, take serum. Okay, then heparin, and then comes your EDTA. Remember, what is the difference between these two vacuotenors? So both of them are EDTA vacuotenors, lavender color and pink color. So lavender color is the classical EDTA vial. The pink color is used usually for blood bank. So it's a EDTA vial only for blood bank, right? And the last one is sodium fluoride. which usually is for glucose. Okay, so it usually has an oxalate. Nowadays it also has EDT as a anticoagulant, but along with sodium fluoride, because sodium fluoride is the one which is going to inhibit enolase and used for glucose estimation. Okay, so remember always, so first after culture it is citrate vial, and the last one is the fluoride vial, and in between you have she. Okay, so remember C, F, and then comes in between she. That's the rule you have to remember. That's the order of flow which you have to remember. Perfect. Okay, good guys. Okay, so that is your order of draw which everybody has to know. Okay, once you're clear with this, now let's come to the next test. So these are another test that they can give you. What is this test, guys? What is this test shown here? This test that we are showing is actually latex agglutination test, guys. This test is latex agglutination test. This is basically used for D-dimer testing. So for D-dimer testing, we do latex agglutination test. Okay, this is for D-dimer testing. Okay, right. Otherwise, if you again another test that you should remember is this is column agglutination. Okay, column agglutination, or better called as gel card technology. Okay, gel card method. Okay, so if I'm asking you gel card method, what does gel card contain? What is the it's a type of column agglutination, and what does it contain? It contains it can have various material, but most common gel card that we use is for Coombs testing. Okay, so for Coombs testing we use gel card method, remember guys. Okay, so yes, so it contains anti IgG plus C3D. That's the composition of this card. Okay, and this matrix inside, if you look at the substance inside, it contains the anti-IgG and C3D. So what you put is you just put the sample in it. Okay, now if the so already anti-IgG is present, so if the red cells are coated with antibody, that is IgG antibody or complements, they will go and cross-link and agglutination will occur, and they will be stuck on the top itself. So anything coming on the top itself, that means it's positive, and something going below, down, that means there is no agglutination, so there's nothing, the cells are not coated by any antibody, so it will come down, right? So it can be used for Coombs testing, it can be used for blood grouping, it can be used for PNH testing. So these are the common cards that we are having. Okay, Coombs, blood grouping, and PNH, these are the common gel cards which we use in our practice. Okay, remember that always. Now next technique that everybody should know is immunohistochemistry. So I've given you a question here, guys. Try to answer this question. Identify the IHC markers. So quickly, everybody. So for identifying any carcinoma, your IHC of choice is always CK. Whenever I'm saying CK, remember CK7 and CK20. The rule has to be formed. Okay, so draw a line above your colon. Okay, so this is a person. Draw a line above the colon. Anything that is above is usually CK7 positive, 20 negative. Anything below this colon, remember it is 7 negative and 20 positive. So colon cancers, okay, so colon cancers are usually CK20 positive, okay, and 7 negative. However, if somebody asks you any confirmatory marker that you have, yes, you can use CDX2 as a confirmatory marker. Okay, 7 positive are breast, stomach, thyroid. Okay, think of any lung adenocarcinoma. So they are 7 positive. Now here is a catch point, guys. If somebody says CK56 positive, okay, so if I change the question and I say, okay, something CK56 positive instead of 756 positivity, then you have to remember it is usually triple negative breast cancers or mesotheliomas. Okay, mesotheliomas or triple negative breast cancers are 5-6 positive usually. So remember, mesotheliomas and triple negative breast cancers are 5-6 positive. Otherwise, other breast cancers are 7 positive. Other lung cancers are lung adenocarcinomas are 7 positive. Okay, even squamous cell carcinoma of the lungs can be CK56 positive. Okay. Now, coming to both positive, suppose they give you, okay, 7 and 20, both are positive. So when both are positive, B for both, B for bladder. Okay, so both positive are usually bladder. Okay, so both positive are usually bladder. Okay, now If both are negative, 7 is also negative, 20 is also negative, then it can be hepatocellular cancer, or hepatocellular carcinoma is one which is negative for both, and other is renal cell carcinoma. So renal cell carcinoma and hepatocellular carcinomas are usually negative for both. These are the common ones that you should remember in CK7 and CK20. So CK is a marker for identifying any carcinoma. Now coming to the next, what is the next one? So let's go to the next one. Okay, lymphoma. So what is the choice, marker of choice for lymphoma? So to pick up lymphoma, we use CD45, which is also called as LCA, leukocyte common antigen. Okay, so leukocyte common antigen is LCA. Perfect, guys. Okay, now for sarcoma, so if you have to pick up sarcomas, you know the marker that you use for sarcoma is Vimentin. So sarcomas are usually positive for Vimentins, right? Coming to the next one, please. Neuroendocrine tumors. So whenever we have neuroendocrine tumors, electron microscopy is going to show you dense core granules, and the marker that you use is chromogranin, synaptophysin, and synaptophysin, chromogranin, and bombesin. Thank you, Ritesh. Thank you for appreciating that. Thank you. Right, coming to the next one is melanoma. So when we talk about melanoma, remember always it is HMB45. Okay, so melanoma is usually HMB45, that you should always remember. Okay, the next you should remember is gliomas. So gliomas are usually positive for GFAP. Okay, so gliomas are usually positive for GFAP, that you should always remember. Okay, apart from that, squamous cell carcinoma, when I'm saying especially squamous cell carcinomas of lung, if I'm saying, they are positive for P40 and P63. Okay, P40 and P63. Okay, so now you can see A. So whenever you have this multiple choice answer, go for the choice that you know first. Like if I say I know carcinoma CK4, CK, so I know A should be 4, so I'm left with B and C options only. Okay, B and C options only. Now I have to see the another thing that I know. So now if I'm saying squamous cell carcinoma, I know it is P40, so G6. So the answer to me is B. So that's the answer. So choose the option that you know well, and then you will be able to understand, right? Okay, guys. So that is your IHC which you have to know till now. These are the basic ones which everybody should know, and one of the very commonly asked question. Okay. So Parthi Kumar said S100, guys. And S100 is a marker which is positive in number 1 cartilage, number 2 nerves, number 3 melanin. Okay, and number 4 histiocytes. So these are the 4 things which come positive for S100. So it's not very specific marker. Okay, that is why we prefer HMB45, which is a better marker for melanin. Okay, the tumor in which HMB45 comes positive, remember PCOMA. Okay, right? So PCOMAs are another group of tumors which are HMB45 positive. Okay, right? So picomas are HMB45 positive, right? Okay, somebody said NSE. NSE is very good. It is so NSE are two types, guys. One is non-specific estrase and other is neuron-specific enolase. So neuron-specific enolase is seen in neuroendocrine tumor. And what about non-specific estrase? It's in hematology, seen in AML M4 and M5. Okay, so that is non-specific estrase. Okay, right. So now lung cancers, which we have told you, I've told you first thing. So CK7 is positive in adenocarcinoma. Just now I've told you if it is a mesothelioma, you have to remember it will be positive for CK5, CK6, and calretinin is another marker. And if you do electron microscopy, you'll be seeing long and thin microvilli. Okay, so maybe another day I'll take a session for you for electron microscopy, quick electron microscopy in pathology. So whenever I have time, I'll just announce that. Okay, so a tall and thin microvilli is very typical for mesothelioma. Whereas in adenocarcinoma, we have short and stout microvilli that you have to remember. Okay. Now, apart from this, you have to remember, apart from CK7, napsin is a marker which comes positive in adenocarcinoma, and TTF1. Okay. So this is positive in adenocarcinoma. Okay. If I'm talking about squamous cell carcinoma, it will be positive for P40 and P63. Okay. And if I'm talking about small cell carcinoma, which is your favorite, it's a neuroendocrine tumor, so it will express all the neuroendocrine markers like synaptophysin, chromogranin, bombesin, and NSE. Perfect. But remember, it can also be positive for TTF1. So TTF1 can be positive in small cell carcinomas also, right? Remember that point always. So lung IHCs or electron microscopies are very important. So in here, dense core granules is a very typical electron microscopic image that has been given. So maybe just before the exam, we can have 20 most expected questions which can be asked you in exam. And these dense core granules are very expected questions, guys. So you should remember this on electron microscopy, right? Okay. Now coming to the colon cancer, I told you CDX2 you should remember apart from your CK20 positivity. Okay, CD20 CK20 positivity, okay, and CK7 negative, right? Now coming to the breast, guys, breast IHC can be an image based question, so you should be able to identify this. Okay, so whenever I'm talking about breast, guys, remember nuclear positivity like this. When you're seeing this dot like brown, so in IHC there's only one rule: brown is considered positive. Okay, so the rule in IHC is brown is considered positive. That's the rule you have to remember. Okay, so here what you're seeing, the brown color nuclei you're seeing, so that means they are ER-PR positive. Okay, ER-PR positive. Okay, whereas if you look at this, this is the membranous positivity. This is what is called as membranous positivity, and this is very typical for HER2-neu. Okay, so HER2-neu basically give you this kind of positivity. So HER2-neu gives you membranous positivity, guys. Okay, right? So membranous positivity can be HER2-neu positive and ER-PR is nuclear positive. Okay, guys. So if I'm going fast, that is because it's a revision session, and you can quickly see that quickly. That is why I'm going little fast, and so that it should not be a wastage of time for anybody, right? So if you look at this case, so this is ER-PR positive and HER2-neu positive. So they can give the spectrum. Okay, so luminal cancers are usually ER-PR positive. Okay, HER2-neu positive cancers are usually HER2-neu positive. Okay, and triple negative are not positive for anything, but they can be positive for CK5 and CK6. Remember that. Okay, now come next one is this one. So if you look at this case, what is this? This cell is basically okay, fine. I'll be. You want me to be little more faster? Fine. Okay. So if you can see here, this is what is called as bubbly cytoplasm. So cells with bubbly cytoplasm are ficelliferous cells. Okay, so these are ficelliferous cells, and these are very typically seen for. These are very typically seen for diagnosis. Come on, guys, what is the diagnosis? Chordoma. So chordoma is a notochord tumor. It arises from the notochord, and the marker of choice is brachyury. Okay, that's the marker that you have to remember because brachyury is also expressed in the posterior mesoderm. Okay, so brachyury is a marker which is seen in chordoma, which you all have to remember. Okay, so remember ficelliferous cells. Now let's go to the molecular techniques which are asked you in exam. So let's quickly look at the molecular questions which can be asked you in exam. Yes. First question on the screen here, guys. So in Sanger sequencing, so Sanger sequencing was the first type of sequencing that was introduced, guys, and is still in centers which do not have NGS use Sanger sequencing. Okay, so this is one of the easiest type of molecular technique to do. Okay, and what do you do? This is you basically use DDNTPs here. It's actually a chain termination method. What is the principle of Sanger sequencing? It is a chain termination method. So basically you use, so if you look at Sanger here quickly, so what you do is you add the primer here. Okay, so you open the DNA, you add the primer. After adding the primer, you add the DNA polymerase, you add dioxy, normal DTNPs, and also you add dideoxy nucleotide triphosphate. So when you add dideoxy trinucleotide phosphatase, they cannot polymerize and the reaction will stop itself. So, and you add this with different colors so that you know which color is which nucleotide. So you add different color for all these four, or you can even add radio tracers. Okay, radio tracers, and Once you do that, the chain termination occurs and you can identify, yes, you can identify what is the sequence. This is the easiest method to be done here. Now the question is, in Sanger sequencing, DTNPs is used because of the following reason. What was the reason? So it fluoresces, it is used to increase the DNA polymerases, it stops the DNA polymerases and they elongate the chain. So it stops the DNA polymerases and it stops the reaction. Now here's another question. What is the sensitivity of Sanger sequencing? What do you think is the sensitivity? So sensitivity is approximately 15 to 20%, which you have to remember. Yes, very good, Midder. There, perfect. You have said. Okay, that's the principle. Dideoxy. So there's no site for 3' bond. That's the principle of it. Okay, and sensitivity is 15 to 20%. That is 15 to 20% DNA abnormality should be present to pick up. To be picked up by Sanger sequencing. That's the sensitivity of Sanger's. So now Sanger was one method which was used earlier. Nowadays, this is the question that they ask you. So, which is the diagnostic method of choice when the tumor cells are heavily contaminated with genetically abnormal stromal cells? We do next generation sequencing. Nowadays, the preferred method of choice for any leukemias or whenever the cells are contaminated by stromal cells is next generation sequencing. In earlier days, we used to do pyro sequencing. That's no more done now. Now we prefer next generation sequencing, which is one of the best methods. In fact, we do next generation only nowadays. Okay, so that is called next generation sequencing because it can pick up even a small amount of DNA, even if it is contaminated by excess stromal cells. Okay, all right. So now coming to the other options, what are they? Amplicon length analysis. Yeah, Amplicon length analysis means, look at this. In cases of fragile X syndrome, if you look, so you know the number of repeats are increased. Amplicons means nothing but excess amplified DNA. Okay, so you know what happens in the normal. Let's say we have 50 sequences of CGG. In pre-mutation, it will double. It will become 100. In full mutation, it will become even more than that. So 200. Okay, so like that, it will keep on increasing. So whenever you have to identify the excess lengths, okay, how much are the excess lengths? How much is the amplicon? This is can be analyzed by amplicon length analysis. Now, problem here is that you have to remember that is more important. So, in cases of trinucleotide repeat mutation, sometimes the amplicon becomes so big that the primers are not able to bridge this. Okay, so in such cases, your amplicon length analysis is going to fail. Okay, right? Now, so what will you do? So in these cases, you will have to do southern blot analysis. So southern blot is done whenever the number of amplification is big. Okay, why? Because in this, no, we have a molecule which will break the amplification site and then we add probe to it. So it can analyze that. So whenever we use southern blot, we can differentiate between normal pre-mutation and full mutation. Whereas amplicon length analysis will not be able to pick up full mutation if the number of sequences are long enough. Okay, so remember that point always. Okay, so whenever we have large trinucleotide repeats, what do we prefer? We prefer southern blotting over amplicon length analysis. Okay, that's a very, very important point you have to remember. Okay, that's about amplicon length you have to know. Coming to single base primer extension. Okay, so name itself says single base. Okay, so it's just taking single base primer extension. So what do you do in this is, let's just say at one point, you know that there is a mutation. Let's say there is a BRAF mutation. Okay, so let's say BRAF V60E is a mutation. We know that at position 600 there is one nucleotide change. Let us say G is changed by A, and you know the formula. I hope you remember. You know that now, Chamchagiri Tirasra. So C always binds to G. Okay, C always binds to G and T always binds to A. So what you do is you tag the C with red color. Okay, you tag the C with red color and you tag the T with green color. So what is going to happen is, so I suppose there is G only. Okay, so that means this is wild type. Wild means something which is normally naturally present. Okay, so this is normally naturally present wild type. So what will happen is C will bind and you'll get red signal. Whereas if it is mutated to A, then what will happen? You'll get green signal. So what will happen is at only one base pair extension is occurring here. Okay, one base pair extension is occurring here. So you're able to identify only one base pair. So if there is mixed wild and mutant, you will get both the signals. Okay, so so the problem is whenever you know a known locus and the problem with this technique is it will give you only one base pair. So if you're wrong in your diagnosis, it will be you'll be messed up. Okay, so remember, only known locus and only one base pair extension when you need, then only you use this technique. Okay, like BRAF mutation at one point, then only you use this. So remember this single base primer extension which you have to remember. Now, so this was your so this is for your known locuses which you have to identify. Now let's come to this qpcr. Qpcr is actually a real time PCR. It quantitates also. Okay, it gives you the quantitation also. So this is basically used whenever you need the exact number of copies. This we basically use in monitoring of CML. Okay, so CML basically we need real time PCR monitoring, or in cases of APMLs, okay, we need real time monitoring, or viruses. Okay, virus loads, like COVID virus used to do that. So basically quantitation. Why is it important in CML and APML? For follow up. Okay, so today there are 1,000 copies, after 3 months there are only 10 copies. You have to follow this up. So this is what is called real time PCR, that you always have to remember. We quantitate that. Okay, so these are the choice of methodologies which you should know in cases of when we talk about PCR. And here are some important catch points that you have to remember, because these are the common things we are doing and can be asked to you in exam. There's a PCR called as ARMS PCR. Okay, right? So ARMS PCR is a PCR which we prefer for doing thalassemia. Okay, especially the beta thalassemia. So for beta thalassemia, we prefer ARMS PCR. Then we have GAP PCR. This is basically done for alpha thalassemia. Okay, so remember that point always. Okay, so there is two type of very commonly, very easily done, because gap PCR is based on deletion. So if you pick deletion, you use gap PCR. So gap PCR is for deletion, alpha thalassemia. ARMS PCR basically for the common mutations which we have in beta thalassemia in our country. Okay, like IVS11, IVS15. Okay, so these are common mutations. So deletion is very rare. So majority of them, they're splice site mutations. So ARMS PCR is preferably done for that. Okay, so 41, 42, all that is basically beta thalassemias are basically picked by our ARMS PCR. That's another point that you will remember. It might come in an exam, guys. So remember that. Okay, right. Now, once we are clear with this, let's come to this technique here, which everybody knows. This is fish. I'm sure all of you know, like you give two colors. So traditionally we use two colors. Okay, let's say we have given green color to BCR, red color to ABL. So whenever there is a translocation and whenever the green comes on red, you get a yellow signal. That is BCR ABL. So that means translocation is there and it is Philadelphia positive. Yes. So diagnosis of choice, if somebody asks you diagnosis of choice for CML and APML is fish. Okay. So we prefer fish, or just now you said PCR. Okay, you do quantitative PCR. Why do you do real time PCR? Why do you do real time PCR? Because you have to follow these up. Okay, so today there are 1,000 copies. After 3 months, there are only 10 copies. So you have to follow them up. Okay, so if somebody asks you which is better, you have to do PCR or fish. So if you do PCR, it is even better because you'll be able to follow up patients. So PCR is better than fish. Okay, so that is very, very important that you have to remember. Okay, so but diagnosis of choice is always molecular in these cases. Now look at this. Apart from that, where else they can give you fishes for amplification? So let's see here. So centromere of chromosome 17, you give green color. Whereas red is given to the HER2 So you get two red and two green signals normal. Okay. So now for two green, you're getting so many red, but they're not very high. So yes, it's amplified. Now again for two green, there's so many red. So definitely HER2 is amplified. So all 2 plus HER2 IHC, you should always do fish analysis. So fish analysis is done for which cases? One, all 2 plus HER2 positive. Apart from that, if on IHC HER2 is negative, okay, then also you should confirm it with fish to know that it is really negative. Okay, so these are the two things where you have to do fish analysis, and this is mandatorily important for all 2 plus HER2 positivity. We do this. Okay, remember that. Okay. Okay, once we're clear with this, this was the quiz question that I'd given in the group also. Identify the abnormality if red is chromosome 22 and the green is chromosome 9. So what do you see here? So most of the people marked it as CML. Why? No, guys. No, it's not CML. CML होता तो कौन सा color आता? Yellow आता ना. So if it is CML, it will come yellow color. You're not getting yellow color. There's loss of red here. So this was deletion of chromosome 22. Okay, so this was deletion of chromosome 22. One arm was lost. So remember that that is deletion 22, which you have to remember. Okay, so look at the color and don't. We should not imagine. Okay, it's 922 दे दिया है तो it will be CML only. Not like that, guys. Okay, so always think in your brain and then try to answer. It's no yellow signal is coming, so this cannot be CML. It has to be something. There's only one red signal coming. It's deletion, probably, right? Okay, coming to the next technique that they can ask you, which is this technique which is showing. So laser light is going, red cells are passing. As soon as the light is falling on it, there is two type of scatter, forward scatter and side scatter. What are we dealing with? Yes, very good, Nikhil and Mitar, they are perfect. Okay, so this is your flow cytometry, guys. Okay, so next important technique that they ask you is flow cytometry. Remember, forward scatter is always based upon size, side scatter is always based upon granularity. Okay, so forward scatter is size, side scatter is granularity. Bigger the size, more the forward scatter, more the granules, more the side scatter. So this is the typical flow plot that they give you. So remember always, so more this has side scatter here and leukocyte common antigen. For all the WBCs, we have CD45. So we use CD45 along with side scatter. So highest side scatter is seen in granulocytes. So these are granulocytes, okay. And then comes the bigger cells with some granules. These are monocyte. No granules, but CD45 bright. These are lymphocytes, okay. These are lymphocytes. And these green cells here, which are CD45 dim, okay, because they're not mature, they're CD45 dim. And even side scatter is less. So these are your blasts, okay. Usually this location of the blast is without granules, so usually lymphoblasts can come at this location. So this is a blast gate which you can see here. Okay, apart from that, there are other cells also which can come here, which is beyond undergraduate level, so we'll not go into details, but for now you have to identify the blast window, at least know these basic cells first. Okay, now let's come to some tricky questions that they give you. So guys, what is this image? Patak shaped cells. Here you can see with lots of granules here and bundles of ore rods in the cytoplasm. These are nothing but faggot cells, guys. Okay, so when they're giving you faggot cells here, you know this is a case of APML. And the question that was given to you here was, this is a 56-year-old male presented with bleeding gums and peripheral smear mein these cells were seen. These are faggot cells, and on flow cytometry, and you get here teardrop pattern. So this teardrop pattern of flow cytometry is very characteristic of APML, and usually you don't see any cells here. You don't see any cells here. This is for 34 and this is for HLA-DR. So nothing is coming in HLA-DR positive and HLA and CD34 window. So CD34 negative, HLA-DR negative acute leukemia is APML. Remember, CD34 negative and HLA-DR negative is always APML. Okay, that's a very important clue that you have to remember. Now, this is one question which students keep on asking again and again and again. This was a question which came as a repeat question, guys. So look at this question here. So again, so if you're looking at CD19 positive cells here, so this is CD19 positive, which you're seeing. This is the B lymphocytes, which you're seeing here. And normal B lymphocyte, you use CD19 and CD40, and you see that these are the cells here, blue, red one. They are 19 positive and 40 positive. I hope you remember these normal T cells, and we have B cells, and T cells have a CD40 ligand and B cells have CD40 receptors. So whenever CD40 ligand of the T cells bind with CD40 receptor of the B cell, this signal is called competence signal. What is the signal called as? Competence signal. Okay, and after this only isotype switching occurs. So what is isotype switching? That is IgM antibody changes to other type of antibody, GADNA. So for that, the signal is very important. So normally we should have CD40 receptors in the B cell, then only the isotype switching can occur. Now this is the patient which they gave you in the exam, and they saw that they were B cells, 19 positive. So they were 19 positive, but there was no population coming here. That means there was no CD40 population here, nothing. So that means there were B cells which were not having CD40. So there was absence of CD40 in these cases. So whenever we saw these CD40 negative B cells, that means they don't have 40. So they are not going to make other antibodies. So they are going to make only one type of antibody now, that is IgM, and that is why this is called as hyper IgM syndrome. What is this called as? Hyper IgM syndrome. Okay, so that is what is called as hyper IgM syndrome. Thank you, Ramya. Okay, so that is called as hyper IgM syndrome, which you have to remember. Now let's go to the next image again. Again, immunodeficiency. This is a 6 months old child presents with recurrent pneumonia. Flow cytometry was done. Which of the tests will you do next to confirm the diagnosis? So look at this now. In contrast to this, look at this. These cells, there are no cells here which are 19 positive or 20 positive. So patient doesn't have B cells at all. So there are no B cells at all. That means they are not having B cells. That means this is A gamma globinemia. No B cells at all. So this is A gamma globinemia. So there is no B cells. So this occurs because of the tyrosine kinase pathway called as Bruton tyrosine kinase. Okay. So if there is absence of Bruton tyrosine kinase, then a patient will not have any B cells at all. So this is what is called as Bruton A gamma globinemia. Perfect, guys. Let's go to the next question here. So this is a 1-year-old child presents with bleeding. He was given FFP, and then they did all the testing. And what did they found was that again you used two markers, 41 and 61, and you saw that majority of the cells were negative. Majority of the platelets were coming in this region. That is, they were negative for 41 and 61. So remember, 41, 61 signifies 2B, 3A. Okay. So 2B3A. So there is absence of GP2B3A, which is very, very typically seen in Glanzmann thromboasthenia. So Glanzmann thromboasthenia is absence of 4161. That means this is Glanzmann thromboasthenia case. Okay, so majority of the population is here in the negative region. Now let's look at the next. Which group of cells is shown in this flow cytometry? If you look at this, you see this cells here, which is positive for 25 and positive for FOXP3, has to be regulatory T cells. Okay, so what are these cells which are positive for FOXP3 as well as 25? It has to be regulatory T cells, which you always have to remember. Okay, so these are regulatory T cells. Regulatory T cells are a very important mechanism of peripheral immune tolerance. Okay, so they help in suppressing the immunity. Remember that point always. Okay, now another use of flow cytometry which they can give you is this. So pancytopenia patient, he also has calf pain. Okay, so that means he's having DPT and his flow cytometry. So pancytopenia with thrombosis, PNH should be a differential diagnosis. So you have to see presence of if 55 and 59 are absent or not. So you saw that there are approximately 26% of the cells which are negative for 55 and 59. Okay, so remember this 55. So 26% is a big number. More than 1% cells, if they are negative for CD55 and 59, that itself is a diagnosis for PNH. Okay, so this is your PNH case. Okay, so PNH is your 55, 59 negative case. Perfect, guys. And now question for you. So what is true about hyper IgM syndrome? All except. So now you tell me. So mutation is in the gene coding for CD40 ligand and CD4 cells. Yes, it can be absence of CD40 ligand in the T cells or CD40 receptor in the B cells or AID in B cells. Perfect. It's X-linked recessive. Yes. And of course, because there are no T cells, so that so T cells have a defect. So that is why pneumonia due to the, how do you announce it, JORC, is common. And of course, because B cells are also not making antibodies properly, there's only one type of antibodies which is being produced as IgM. Others are not produced. So again, pyogenic infections is very, very common. So everything is correct here. None is false. Okay. So these are all correct statements about hyper IgM syndrome, which you have to remember. Okay. So immunodeficiency questions are very important and they can be given to you in exams. Okay. So with that, we finished today's session. Okay. So this was short session which basically 1 hour session basically for your techniques. So there are more techniques also, guys. So whenever I have free time, I'll announce and take it. And thank you for watching. happy preparing. Okay, read well and study well, and I'll see you again with some other midnight session soon before your NEET exam. We'll have a lot of sessions, and yes, we'll have a session of 20 most expected questions, probably on 26th. Okay, 26th night, we'll have that session, guys. So, all the best. Bye bye. Good night. Signing off. Bye bye, guys. If there is any query, do feel free to message me. Okay, good night. Bye.